Hello, everyone, and welcome to Understanding the Complexities of Liver Disease and CF. My name is Meghana Sathe, and I'm a pediatric gastroenterologist and the co-director of the Pediatric CF Center here in Dallas, Texas at UT Southwestern and Children's Health. I was also a Digest mentee, and I'm actually now one of the faculty, which is awesome. In addition, I recently had the privilege to help write the most recent CF liver disease guidelines, which hadn't been rewritten since 1999. I'll be moderating the session today and will be introducing our other speakers in just a moment. Before I do, I just wanted to provide a few housekeeping items. This session is being recorded and will be available after the event on the CF Foundation YouTube channel. You'll be notified by email when the session recordings are available. We will be taking audience questions during the session. We encourage you to submit your questions at any time in the chat box. We won't be able to answer questions about individual diagnosis or treatment plans, but we encourage you to take the information you hear today and have those conversations with your care team. We'll do our best to answer as many questions as possible at the end of the session. Now I'll first go through our disclosures for today's talk and then review the objectives we hope to cover today. So the first slide, these are the disclosures for myself and Dr. Assis. Next slide is the general disclosures. And now to the objectives. So today we're going to start with talking about the liver and its functions without CF. Then we're going to talk about why CFTR is important in the liver and what role it plays. We're going to discuss next the terminology of CF liver disease, and that's new terminology that's recently come out. Then we're going to talk about the guidelines in terms of screening, diagnosis, and management. And then we're going to meet two of people with CF who are also going to talk to us about living with liver disease and CF, talk about liver transplant and life after transplant, and then we'll conclude with a summary and take your questions. So first, I'd like to introduce Daniela Cortez. She has cystic fibrosis and is post-liver transplant and is enjoying her time in Germany right now as a student, and I have to thank her very much for coming because it's 1 a.m. there. And unfortunately, we're missing Charlie, who is also a patient with cystic fibrosis, Charlie Farrell, and he contributed significantly to the slides, but unable to join us tonight as he's feeling a little under the weather. So that takes me to our first speaker, Dr. Assis. So Dr. Assis is an adult transplant hepatologist at Yale, and he and I were actually in the first Digest class together and have remained friends and colleagues through the last 10 years. We both got the opportunity to work on the CF liver disease guidelines together, and I'm really excited that he's here to share our work with you. So I'll turn it over to David.
Thank you so much, Meg. Thanks for everyone for the opportunity to speak today. It's a real privilege. And over the years, as Meg mentioned, are wonderful patients and persons with CF who have liver involvement. And hopefully this session will be useful for getting some sense of the understanding of the degree to which the liver can become involved in the context of CF. And I imagine there probably are varying levels of familiarity and levels of questions. And so hopefully we'll be able to speak to everyone at various different levels of understanding and then address more complex questions or even more basic questions during the Q&A. So with that, we'll go ahead and get started. So I always think it's useful to begin any discussion like this by reviewing just the basics of what the liver is and what its functions are so that we can put into context then what could potentially become abnormal and potentially go wrong in cystic fibrosis. So why don't we start then just discussing some of the key functions of the liver. First, it's important to realize the liver for our body and also makes blood clotting factors. This is very important because it helps us to regulate not only the balance of fluid and protein, but really the proteins perform so many roles throughout our body and our metabolism that without the liver, it would be very hard to have these key functions, including clotting factors. can advance. The liver removes toxic substances from the environment, things that are always coming in through the external world, through the portal vein, which we'll describe in the next slide a little bit further, but also the products of our own body's metabolism, which the liver needs to be healthy enough to handle. The liver also metabolizes nutrients that we receive, of course, from the diet, as well as most, not all, but the vast majority of medications that we ingest. The liver is critical in that role. And so the ability of the liver to metabolize and convert the medications into active substances and deal with nutrients is an essential function for our body. The liver also prevents infections, of identifying and removing infectious organisms that might come in through the blood system from the gut before there is an opportunity to cause harm to our bodies. And this is a role in the way that's been described as a vascular firewall. The liver protects our body from and that key interface with the external world. In addition, the liver helps to maintain adequate levels of sugars, minerals, and vitamins. So in addition to helping us to deal with what we are ingesting, how to process and to maintain healthy levels of sugar, such as glucose, not too high and not too low, by having adequate stores of these key essential nutrients. And without a healthy liver, it would be very important to regulate and to absorb properly the amounts of vitamins that are necessary for a healthy body. Lastly, in terms of some of the key functions, at least, the liver makes bile, and bile has increasingly recognized important roles in our body. Not only does it help us to digest food by being excreted from the gallbladder and from the liver into the digestive tract, so it has a bit of a detergent action, so it's an important aspect of a healthy nutritional absorption, but it also helps us to absorb vitamins and also to regulate our metabolism in the shunting mechanism through the not only the gut, but also the blood vessels in the abdomen. So it has an increasing role, increasing recognized role as a hormone regulator of metabolism. Why don't we spend a minute then discussing where the liver is in terms of the anatomy and how it's positioned within our body. That might help us to get a sense for what could potentially become apparent in the context of any chronic liver disease, as well as more specifically in the context of cystic fibrosis. If we take a look at the upper left-hand corner, or if we start with the portal tract, this is a microscopic cartoon of the microscopic appearance of the liver. There's something called the portal tract, which one being the bile duct. And we know that the bile ducts are important to help us to, as a conduit for the bile, which is made in the liver cells called the hepatocytes. The bile trickles down in a coordinated manner that then eventually empties into the intestines. We know that there's an artery depicted in that more bright red cartoon structure, which also brings key blood to the bile ducts themselves and to some of the liver tissue, as well as a vein, which is a small conduit from the portal vein, the larger blood vessel that drains all the blood that is feeding the intestines. If we look at the bottom of that first slide also, we will see that the bile ducts, when you have this biliary system, which is almost like a tree in winter, starting with very small bile ducts that then become larger and eventually coalesce into the common bile duct, which empties into the intestine. You can see which serves as a reservoir for bile, and you can see also that that is close to several key structures, including the pancreas. So the anatomy of the bile duct system, the pancreas, and the liver are all in close proximity on the right upper hand corner of our abdomen, and particularly for the liver and the gallbladder. And then lastly, on the right side of the slide, you can see, again, what I illustrated or described before, which is the liver receives blood from the intestine, has that key role in processing a lot of the absorption of nutrients and external products, medications that are ingested by receiving this blood through a key vein called the portal vein. The next thing that we can turn our attention to is, where is CFTR in this whole system and what does it do? I'm sure many on this program have an acute awareness of CFTR and perhaps have in the respiratory tract. We think perhaps less commonly in the context of CF of where it is in the liver and the bile ducts and how that can affect us. So just by way of review, CFTR key protein that is, of course, at the heart of cystic fibrosis in terms of the diagnosis. It is not expressed in the hepatocytes called the liver cells, which is important to recognize. However, it is very highly expressed in the biliary tree. By biliary tree, I'm discussing, again, these bile duct cells, also called cholangiocytes, which are the lining of those tubules that drain the bile from the liver into the intestine. It is highly expressed there and also in the gallbladder. And you can see in the cartoon that when the liver cells, the hepatocytes, make bile, it needs to flow through a healthy set of tubules, the bile ducts, and the ability of that fluid to remain healthy and not to damage the liver, the bile ducts, on a well-functioning CFTR protein. So defects in CFTR can, at their principle, lead to an abnormal composition of bile. And how the liver responds to that may be leading to a degree of inflammation. It can also lead to dysregulation in metabolism and some fatty tissue within the liver. And furthermore, in some patients, there can be a disruption of the integrity or the normal composition of the bile ducts, leading to scar tissue and something called strictures, which can lead to disruptions in bile flow. Next slide. So the real question, and something that we do not fully understand, to be quite honest, is how exactly can a defect or an abnormality in CFTR actually cause liver disease? I think if we're honest, we need to recognize that this is not completely understood. And I think it's important to realize this because when we discuss throughout this session the existence of liver abnormalities in cystic fibrosis, one thing we need to put out there is that despite common genetics, genetic mutations between different patients, for example, delta 508, even homozygous mutations, not all patients with the same genetic abnormalities go on to develop all the different complications, not only throughout the body, but particularly when it comes to the liver. So there probably is some additional factor or set of factors that may be involved in unmasking this. We can go backward by one slide. Yeah, thank you. Perhaps the clinical presentation, the different manifestation of cystic fibrosis is something that probably depends on an interaction between the genes, which we know to be abnormal in CF, but also things that some patients or persons with CF might have another genetic mutation that can contribute to the risk of liver problems. And one that's been studied for a number of years and also confirmed in a recent article just released in a journal called Hepatology is an abnormal gene or allele, I should say, for a condition called alpha-1 antitrypsin, which is called the Serpina Z allele. It's been shown that individuals who have that mutation might be at higher risk of developing liver abnormalities in the context of CF. Another abnormality could be the presence of metabolic syndrome, which some might be familiar with this term, really denoting a concurrence of elevated weight or obesity, diabetes, high blood pressure, high cholesterol. It's possible, at least, that in the context of those abnormalities, that the CF abnormality, CFTR abnormality, can then prod the liver along to not function quite so well. Ironically, obesity and metabolic syndrome, which is severe malnutrition, we know also can be a risk factor for any chronic liver disease. And we think that this can also be relevant in the context of cystic fibrosis. We are just starting to understand a little bit about the microbiome and how that can affect the liver, not only in chronic liver disease, but also in cystic fibrosis. And I think several research groups have made some interesting recent progress on trying to see how that really works in the context of cystic fibrosis. And I would anticipate in the years to come that there will be a lot more that is discovered in that regard. Drug-induced liver injury. I mean, we'll talk a little bit about ETI and Trikafta, for example, throughout the session, although it's very unusual, although possible for this medication to harm the liver. There are myriad medications that can sometimes cause some liver harm, and perhaps that can be unmasking in liver abnormalities that can become chronic. Toxins, such as overuse of alcohol, CFTR abnormalities, as well as blood clots called thrombophilia, infections, and a poor diet. The last thing I'll leave you with for this portion of the discussion is that there is not a single manifestation of cystic fibrosis. Some patients with cystic fibrosis might have some fatty tissue in the liver called steatosis, but not much in the way of scarring. Other patients might have accumulation of bile, which causes cholestasis, which is the term for that, which can cause inflammation. Some patients will have significant fibrosis and can develop cirrhosis, which is severe scarring in the liver. That can also lead to a high pressure system in the veins of the abdomen called portal hypertension. Some patients don't have significant scar tissue, but might have changes to the appearance of the liver tissue and the blood flow, which can be compatible with a condition called nodular regenerative hyperplasia. Some patients can have that fibrosis that can cause a backup of bile and jaundice. And lastly, some patients may not have much in the way of liver manifestations, but gallbladder disease and a need for gallbladder removal. We hope to make progress in the years to come to understand exactly what leads to the different manifestations, but it is important to recognize at this stage that there is an interaction between the genes and the environment, and there are multiple manifestations of cystic fibrosis. And with that, I will pass the forum over to Meg for discussion of terminology.
So as you can see by David's discussion, there are many different definitions, or could be many different definitions of what exactly CF liver disease is. And you can imagine the confusion with patients and families, let alone researchers. So recently, the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition published a guideline to try to make a more uniform definition so that we're all speaking the same language, whether we're clinicians, researchers, and patients. And so I think it's really important for all of us to understand this new language, because it's going to get thrown around a lot in English in your clinics. So the two definitions, basically, we've taken liver disease and we put them in two buckets. The first bucket is the bigger bucket, which is cystic fibrosis hepatobiliary involvement. And this looks at what your liver enzymes are doing. Are they elevated? Are they not elevated? Are they sometimes elevated? What does imaging look like? So if you had an ultrasound of your liver, does it look like the liver is smooth? Does it look like it's got nodules in it? Does it just look kind of rough or bumpy? And then also it looks at the spleen. So what is the spleen looking at as well? And then, although not common, some patients have had liver biopsies. So what does that biopsy look like? What does the histopathology look like? And how does that contribute to whether we think the patient has CF hepatobiliary involvement or advanced CF liver disease? We now have new ways to look at liver stiffness. That's kind of a marker for fibrosis or scar tissue in the liver. David's going to talk about that a little bit later on, but this also contributes to the definition. And then whether or not you have portal hypertension or not. As David was mentioning, you can have cirrhosis or scar tissue, or you can have this nodular regenerative hyperplasia, where you have nodules that are not scar tissue, but both can actually be present with or without portal hypertension. And so do you have that? Does that make your liver disease look different? Then there's biliary manifestations. This is a little outside of just liver disease, but do you have gallstones? Do you have stones somewhere else within the liver? And then, as we know, malignancy is becoming more recognized in patients with cystic fibrosis later on with colon cancer. And so we want to evaluate and make sure that we're screening for patients with liver disease, whether they are developing any signs of malignancy within the liver or within that biliary tree. So that all falls into one bucket. And there's different ways in which we grade this and we follow it, but we have a uniform language now. The other bucket is advanced cystic fibrosis liver disease. And so this is really your patients with cirrhosis or non-cirrhotic nodules, and then determining whether they have portal hypertension or not. So that's the next big bucket. And that's kind of how we created the guidelines as well in terms of management, as you'll see later. Next slide. So now we're going to spend a minute talking a little bit about the manifestations of decompensated advanced CF liver disease. So what can happen if you have advanced CF liver disease and things are getting a little complicated? So I usually describe what happens as sort of like a plumbing system. As you develop scar tissue, or if you have nodular regenerative hyperplasia, you still have some resistance that builds up in the liver. And if you can imagine, you have blood going into the liver, and if you have resistance in the liver, then things can start backing up. And so if things start backing up, many different consequences may take place. One of those is that your body will form abnormal blood vessels. It's trying to make sure all this pressure goes somewhere. And so it will create something called varices. And the most common place we talk about varices is in the esophagus, but they can happen in the stomach, they can happen in the intestine. And sometimes these varices, because they're actually abnormal, they can bleed easily. And so that can cause some significant problems. Sometimes the back pressure can actually cause fluid to build up in the abdomen, and this is called ascites. And if this fluid gets infected, as David was mentioning, the gut microbiome and how the liver plays an important role in trying to prevent infection. Well, if you have a sick liver, it doesn't do as good a job of preventing translocation of bacteria from the gut, sometimes into the liver, into the bloodstream, and maybe into this fluid. You can actually get something called spontaneous bacterial peritonitis, which is an infection of that fluid or that ascites. Other consequences of decompensated advanced liver disease can include something called hepatorenal syndrome. And this is where your kidneys actually stop working really well because of your liver disease. And post-liver transplant, they recover. And this is not just seen in cystic fibrosis liver disease, but is seen in many chronic liver diseases. Another complication is hepatic encephalopathy. So as David was mentioning, that the liver is sort of a clearinghouse for toxins. It helps metabolize medications that come through. It also helps clear ammonia, which is made by bacteria in your gut and then goes into the liver to be cleared. Well, if the ammonia is not being cleared, then it can actually cross the blood-brain barrier and cause some neurologic abnormalities. And in the next slide, you'll see some of those that Charlie had experienced, and he was telling us about them. So I'll share those with you. The last thing that I have on here is portal vein thrombosis. So again, due to the back pressure, then your blood isn't flowing as steadily as it should. And so it kind of stays there, and blood is supposed to clot. And so if it starts clotting because it's not flowing properly within that portal vein, it can actually form a clot. And that clot can cause worse back pressure and actually make some of these complications we've already discussed even worse. Next slide. So I'm going to share a few experiences that Charlie has had that he wanted to make sure to discuss. And I apologize, my light just went off. Okay. So he wanted to make sure that we discussed what ascites is, because it's something that's not often talked about. And so, he mentioned that not only, as I said, there's fluid in the abdomen, but he was really mentioning how uncomfortable this can be and how it can be difficult then to cough and clear phlegm because your abdomen is distended. And the way this is treated is with a medication or a combination of medications called diuretics. And so what diuretics do is they try to get rid of that excess fluid, but that can also make you need to go to the bathroom a lot. So that can be challenging, especially if you're on multiple different diuretics. It can also mess with the salts in your bloodstream. And so it has to be monitored carefully. Another thing, sometimes if there's a lot of fluid and the diuretics can't get it under control, is that you may need something called a paracentesis. And this is actually where they put a small needle, into the abdomen, and we actually pull out the fluid. And that can be helpful to get some relief, especially if your belly is really distended. But the challenge with that sometimes is the fluid comes back pretty quickly. So it's not a permanent solution, and we try very hard to never actually leave a connection or a drain in the abdomen. So if we need to do a paracentesis, it's just with a needle, and we may need to repeat that at some point in time. So hepatic encephalopathy, sometimes when you read about it on the internet or something like that, you're really thinking of the patients who maybe are in a coma or something like that. But more common is actually a very subtle level of hepatic encephalopathy that makes your brain kind of foggy. It can sometimes just make you not perform as well at school or in your work tasks. Your family may notice things before even you do. And so there's different medications that we can use to try to help clear that ammonia. And most commonly, we use a medication called lactulose. It's a liquid. It's an undigestible sugar that pulls toxins from the blood and increases, and usually they increase the amount if you're having higher levels of ammonia, or as he mentioned, a hepatic encephalopathy event. Um, the problem with lactulose is makes you poop a lot. So we want to get the toxin out. And if we increase doses, then you may actually have diarrhea. Another medication that's often used is Xifaxan or rifaximin. And this is a pill, and you can take that twice a day usually. And that helps control the gut bacteria that makes the ammonia and the extra toxins that are causing you to be all foggy. Sometimes we actually use a combination of these medications, but that's the most common things that we use outpatient for hepatic encephalopathy. And then one thing that we didn't mention earlier is sleep changes. So Charlie was telling us how, with his liver disease, literally sometimes his days and nights are flipped. And so during the daytime, he is tired and exhausted and wants to sleep. And during the nighttime, he's awake and ready to go. And this can sometimes happen for a short period of time if your ammonia levels are high, or it can happen all the time. And so for him, he actually needs to take some Benadryl to help him sleep during the night. So now we're going to move on to Daniela's experience.
Thank you. All right, Daniela, one of the reasons why we wanted to have open this up as the patient perspective is that you yourself had some experience with some of these complications of advanced liver disease, in particular varices, and then bleeding and the need for treatment, as well as the need to adhere to particular dietary requirements to try to keep the advanced liver disease at bay. So I was wondering if you could share a little bit what your experience was in dealing with the varices in particular, and then we can talk about the nutrition.
Yeah, so when it came to these to the varices, I was warned that due to everything going on in my body, that my varices bleeding would be a real possibility. In the back of my mind, I did not think that that was something I had to worry about because I didn't really have a lot of liver failure symptoms. But it wasn't until one day I went to the restroom, and right after I got up and I looked into the toilet bowl, I saw bloody stool. And I looked straight in there and I was like, huh. And I got really nervous. So I thought, okay, maybe it's just a one time occurrence. I ignored it, flushed the toilet, went about my day. I thought it would be, like I said, a one time occurrence. It was not. It happened again later. And then I realized, okay, it's not a one time occurrence. So I called my transplant team, to which they said, okay, you're going to have to come in because we have to do an endoscopy for a possible ligation of varices. And at the end, it was a esophageal bleed with my varices, and I did get ligated, and it was terrifying. But I did get over it, and I did realize that, okay, these things do happen. So I got to stop taking it so lightly.
Yeah, it certainly can be scary to have some treatment, and I fully understand what you're saying, Danielle, that knowing there are varices and seeing that something can happen to them and need treatment are often a difference between having the concept and going through it. I'm glad that you had the presence of mind to contact the transplant team and to come in to be treated, because that's so essential. How was your experience then during the pre-transplant period with the dietary aspects of having this advanced liver disease, since we know in particular that ascites, that fluid buildup, and all the other aspects of the liver can respond poorly to certain diets? So what was the conversation at that point, and how did you navigate all that?
So for me, ascites never really happened, but the dietary things that they did mention to me, because since my pancreas, the CF, but I didn't know that, but they associated it with symptoms of my liver. They told me to cut back on a lot of greasy food. I did get on enzymes, but I like pizza. So, I think here and there, as long as you take your enzymes, you're good. But they did tell me to balance out my meals, fruits, vegetables, adding healthy fats, being able to just understand that, like, my liver does not process vitamins and things the right way. So I had to make that easier for me and my liver. So they do encourage taking like extra vitamins and, again, the fruits and vegetables, balancing that out because, you are also at risk for diabetes. So it's a give or take situation. I did still enjoy a lot of, foods I shouldn't have eaten because, as my dietitian said, you give and you take. You're not like fully restricted from eating. It's just watching what you're eating and how you're consuming it and how much of it. So it's okay. It's a struggle at first, but you start to get the hang of it.
Yeah, it's certainly a process, and looks like you handled it quite well despite the challenges. Thank you, Daniela. Then is move towards some discussion of the best attempt, I would say, thus far in the current era of trying to make sense of this from the CF Foundation with the recent guidelines that came out. If we take the pathophysiology, the complications, the different manifestations, the advanced and the milder forms of CF liver disease, these consensus recommendations, which were just published fully this year, I think will serve as a contemporary document that patients with cystic fibrosis liver complications and providers will make good use of, and they're fully available to the CF community. We'll go through some of the key aspects because that will help to guide the remainder of our discussion in the next several slides. So the first thing to consider, given the fact that anyone with cystic fibrosis can be at risk for hepatobiliary manifestations of CF and potentially advanced liver disease from CF, is thinking broadly about who should be screened. And I think the group felt quite strongly, as you might imagine, that the slide. Thank you. And that's important to emphasize because although the majority of patients with advanced liver disease from cystic fibrosis have been identified traditionally in the teenage years and in early adulthood, there are examples of children and earlier preteens, as well as adults who fortunately are living later and later into life, also developing this. And so it's important to recognize that anyone, regardless of age, should be considered for cystic fibrosis liver complications. The next thing to consider is what should that screening consist of? And there are probably several different modalities that should be considered, but some of the key aspects are, number one, to have the patient receive annual labs, which are spelled out there, some specific liver tests such as AST, ALT, bilirubin, GGT, alkaline phosphatase, as well as a marker of spleen or portal hypertension abnormalities, such as the platelet count. There should also be an annual physical exam of the abdomen, and this should focus specifically on the liver, as you might imagine, looking for either a very small and shrunken liver or for an abnormally enlarged liver, as well as palpation and an evaluation of the spleen itself, since enlargement of the spleen, as Meghana mentioned, can be a physical sign of high pressures in the veins of the abdomen called portal hypertension. The next aspect is to consider imaging. And there was some discussion from the group, but there was a wide consensus that perhaps starting around the age of 3, there should be an abdominal ultrasound at least every 2 years in the pediatric range, going up until adulthood. And the reason for this is that there is a risk of development of liver manifestations with the abnormalities in the liver, particularly in that tissue, during the first few decades of life. For adults with cystic fibrosis who were either diagnosed in adulthood or who did not have manifestations of advanced liver problems during their teenage years, there should also repeat exams are at the discretion of the patient and the provider. And of course, the goal of doing this testing, and we can advance, is to determine, is there evidence on examination of the body, the abdomen, labs, and or imaging of liver involvement. Next slide. Yep. If there is involvement or evidence to suggest hepatobiliary involvement with cystic fibrosis, as you can imagine, the next thing is to characterize this. And the key aspects here are to understand what is abnormal and to what degree. One aspect, which we will not focus on too much here, but we can discuss further in the Q&A, is to understand if there are problems and complications related to either gallstones or a stone, for example, which can be lodged in the bile ducts, causing some jaundice and pain, or cholangitis, which is an infection of the bile, or strictures. If there is evidence of a blockage of the bile ducts, that should be dealt with right away, and that is a determination based on the appearance of the liver on the ultrasound as well as the labs. But for particular complication, and we can advance, the key aspects are in the next 2 recommendations. Number 1 is there is a recommendation to do a baseline assessment of the degree of liver fibrosis, which I'll describe further in the next few slides. But the goal here is to understand what degree of scarring is in the liver at that time point, whether there's no scars or severe scars, even as much as cirrhosis. And this can be done these days non-invasively without the need for a liver biopsy through various modalities, which I'll describe. The last aspect, and we can advance further, is just to make it clear that, as I mentioned earlier on, there is a possibility of additional risk factors being present that could lead to further triggering liver disease in someone with cystic fibrosis. I see a question here in the chat as to whether the MZ phenotype for alpha-1 antitrypsin deficiency could place someone at risk, and the answer is yes. The single allele, the Z allele in particular, for alpha-1 antitrypsin can be a risk factor for somebody developing liver disease. It is a good question as to whether that should lead to more foundations and with ultrasounds, laboratory tests, and measures of fibrosis. I think it should be guided based on what is present at baseline in terms of the frequency of monitoring. Just having a Z allele will not unequivocally lead to advanced liver disease, but it is a risk. Yeah. And we can move on to the next slide. Okay, great. So the assessment of liver fibrosis, I think, is an important aspect for us to spend some minutes on. There was a question also in the chat about liver stiffness, and this is what I'll address next, so hopefully this will answer that question. We know that chronic inflammation of the liver can lead to scars or fibrosis, and you can see in the cartoon on the right that the space between the blood vessels and the liver cells can be occupied by that green, in this cartoon, green substance, which is the scars and the fibrosis. That really makes the liver stiff because the liver cannot have the blood flow as normal as it would need to be. And so you can see how we could potentially use that stiffness to assess the degree of fibrosis and scarring, because we know that more scars equal more damage to the liver. And you can see in the fibrosis all the way through stage 1, 2, 3, and 4, there's different grades of fibrosis. And that does help us to understand what the prognosis as well as the management should be. It's very important to distinguish between someone who has no fibrosis and somebody who has cirrhosis and all the levels in between. And we can advance to the next slide. Now, this process can occur in anyone. It is not necessarily specific to cystic fibrosis, but the recent recommendation guidelines did try to assess how to understand stiffness and measures of fibrosis and portal hypertension in persons with cystic fibrosis. We can advance the next two. There are two main ways to do this. One is with blood tests, which can be used to calculate some scores. You can see several listed here, such as the APRI, the GPR, and the FIB4. We don't need to spend too much time on the formulas, but basically there's calculations based on blood tests that can be ordered routinely that can give a sense as to how advanced the liver disease is. And you can see listed there were some thresholds based on the literature, oftentimes with insufficient data to be fully sure, but can suggest the presence of advanced liver disease. But I'll focus mostly on the lower row, which is the liver stiffness measurement, including by a mechanism called transient elastography and also shear wave elastography. This is a measure of stiffness of the liver because overall, stiffness of the liver correlates with the degree of fibrosis. It's not a perfect test, but it's a very good estimate of fibrosis. And you can see several numerical levels there that are indicated that can give clinicians a sense as to how much scar tissue is in the liver. And we can go ahead to the next slide. This is illustrated by this one technology called transient elastography or FibroScan. It is a technology that has become quite widespread at gastroenterology and hepatology clinics throughout the United States and certainly at referral centers. It's like an ultrasound machine which just measures the stiffness of the liver. The more stiff the liver, the more correlation that often tends to have with the degree of fibrosis. And so in the recent recommendations, the fact that everyone who is found to have fibrosis is through something including transient elastography to understand where we're starting. I think that's important because we heard from patients and clinicians alike in this guideline process that it doesn't make a whole lot of sense to just find out and later on that there is advanced liver disease if there was the opportunity to understand sooner what is happening to the degree of fibrosis. And this type of test is highly recommended at this stage as a baseline. And we can advance to the next slide. And with that, then, with that information between examination, labs, baseline assessment of fibrosis, the next question is how to manage this liver involvement from CF. And for that, I'll pass the back to Meg.
All right. So in terms of the management of liver disease and CF, again, we stuck with these two categories, right? Cystic fibrosis, hepatobiliary involvement, and then advanced CF liver disease. So in terms of once you're diagnosed with CF hepatobiliary involvement, what does that mean day to day when you go to clinic? Well, one, it means that you're probably going to be referred to a gastroenterologist or a hepatologist who is familiar with cystic fibrosis liver disease. And that may be someone who is in your clinic. That may be someone who you have to go see in a different clinic. In addition, we're going to ask you to do a few more things than usual. One is a lot of clinics now have pharmacists, and so we're going to try to see if we can get the pharmacist to see you every 6 months. And you may see this person in clinic, or on the back end, potentially your team is having a pharmacist review your medications. The reason for this is, as David had mentioned earlier, in terms of the jobs of the liver, is to clear toxins and to clear medications that come through the system. And so we want to make sure that the medications you're taking are not harmful to the liver and that there's no drug-drug interactions. Sometimes when the liver is sick, certain medications that would be fine in a patient whose liver isn't sick may need adjustments in dosing. And this can actually include ETI or Trikafta. So we really want the pharmacist to not only know what medications you're taking that were prescribed, but anything you might be taking over the counter, any supplements, herbals, anything like that. So it's really important that they have full disclosure onto what you're taking so that we can kind of make decisions together about how these medications interact and what is safe for the liver. Annually, with CF hepatobiliary involvement, we need to feel your belly. And so the reason to feel your belly is we're looking to see what your liver feels like. Is it enlarged? Usually your liver and your spleen and your body actually sit below your ribs. And so I shouldn't be able to feel them. But if you have liver disease, then your liver may be enlarged and it may be soft or firm. And I might be able to feel it below your rib cage in your abdomen. The same goes with that back pressure. You can have an enlarged spleen, and so I may be able to feel that. Sometimes with advanced liver disease, your spleen actually gets bigger and your liver starts shrinking because of the scar tissue. We can also appreciate things like development of ascites in a physical exam. And so there are reasons for us to really want to feel your belly once a year, not just to make you come to clinic. There was a question in the chat about the labs. And so the good thing about these liver fibrosis indices that David just described, the APRI, GPR, those are actually calculated from labs that are part of your CF annual labs. And so you start having those done at year 1. And if you're diagnosed by newborn screen, and at least annually. And so we can actually use the labs that you're already getting to help calculate some of these fibrosis markers. And in our center and many other centers who have electronic medical records, we've actually been able to program our electronic medical record so that these are calculated for the clinicians in clinic every time you see them and you have new labs. So there's less likely chance of mistake of calculations because it's already in there. And then elastography. As David pointed out, there's many different ways in which we can do the elastography. There's the FibroScan transient elastography, which many of us have those machines in our clinics and are able to do those as point of care when you're at a clinic visit, whether that's a clinic visit in a CF or in your GI or hepatologist office. If that's not available, as noted earlier, we're going to ask you to get a baseline ultrasound, and in the pediatric clinics, we're going to ask you to get that repeated every 2 years. As you become an adult, if you have abnormalities, you'll probably need to get that ultrasound done every 2 years or 3 years anyway, and they can actually do the elastography with the ultrasound, and so we can combine those as well. And then in terms of the regular ultrasound, which, as we said, you need a baseline, and then every 2 years in pediatrics, and then maybe spaced out a little bit more when you're an adult, that actually also helps us look at the size of the liver, the size of the spleen. It also tells us a lot about the texture of the liver and the spleen, whether it's smooth or whether it's rough. Next slide. So now I'm going to move on to what about management of advanced CF liver disease. So here, we really want to make sure that now you really want to be plugged into an experienced gastroenterologist or hepatologist who has experience in CF. And preferably, we actually want you to see someone at a liver transplant center or a gastroenterologist, hepatologist who are at a liver transplant center and have those connections. It doesn't mean you definitively need a transplant, but those are all the people you want to be involved in looking at your case and making sure that they're having conversations. So the frequency of visits and testing is going to go up for pretty much everything to about every 6 months versus in the last slide where some things could still be done annually. So as was mentioned earlier by both David and Daniela, the liver is responsible for processing sugar. And so patients who have CF liver disease are actually at higher risk for also developing CF-related diabetes. And so we actually have a clinic at our center where we have the endocrinologist and ourselves and the pulmonologist together, and that's where we see the patients who have liver disease. And so if you're diagnosed before the guidelines say to screen for oral glucose tolerance test, which is at age 10 normally. So if you're diagnosed with CF liver disease, advanced CF liver disease before age 10, then we recommend that you actually start your OGTTs early so that we can make sure to diagnose CF-related diabetes if it's there and treat it properly with insulin so we can maximize your nutrition and your growth. In addition, we're also going to have you see the pharmacist, as was mentioned earlier. That physical exam, now we really want to feel your belly at least every 6 months and notice if there's changes. We're going to get liver labs more frequently. So you may still get your annual labs once a year, but that portion of the annual labs that tells us about how your liver is doing, whether there's inflammation or how it's working, those are going to be done more frequently. Now, you all see a dietitian usually once a year. Again, nutrition becomes of utmost importance, as Daniela mentioned. Once you have advanced CF liver disease, there's a lot of factors contributing to whether or not you're going to be nourished or not. And there's a lot of recommendations, assessments that we want to have, especially if you're moving towards transplant. And so you're going to probably see that dietitian at least twice a year, if not more often. Now, in terms of pediatrics and adult, there's a little bit different recommendations for cancer screening. And so in pediatrics, we actually use something called an alpha fetoprotein level, which is more commonly elevated, and then also ultrasound. And then in adults, we usually just do the ultrasound. So those are a little bit of differences, but the point is that annually, whether you realize it or not, we're also screening for liver cancer. And so we're going to be on top of that. Now, what about if you develop portal hypertension? So Daniela talked a little bit about these varices that she developed and how they needed to be ligated or banded, where we put a little rubber band around these varices to try to prevent them from bleeding. So if you develop portal hypertension, we may decide that we're going to go look and see whether or not you have varices. And if you do, then we're going to follow the recommendations, or the guidelines recommend that you follow the recommendations that are out there for other chronic liver diseases. And so for adults, we're really going to follow the guidelines of the AASLD or Bovino. And in pediatrics, there are no good recommendations necessarily to go and look and intervene prior to having a bleed. So we're going to continue to follow our colleagues who are studying chronic liver disease in deciding whether or not to look for these varices. Now, on an individual basis, it may vary a little bit, but these are the guidelines that we are recommending. Before I move on to talking about modulators, there was a question in the chat about using ursodiol. So ursodiol is a synthetic bile acid that's been used to help with bile flow. And when we develop the guidelines, which are evidence-based, the evidence shows, and many of us who've used urso, that ursodiol can make the liver enzymes look better. It can improve your numbers, but there is no evidence that it can prevent the development of advanced CF liver disease. And so it is not recommended for treatment to prevent advanced CF liver disease. There may be other reasons that your doctor decides to put you on ursodiol, but it is not going to help prevent. It may make the numbers look better. So that's one point about ursodiol. We can move to the next slide, which is something I know everyone wants to talk about, which is, what about CFTR modulators in the liver? Well, if you have liver disease, so if you have cystic fibrosis, hepatobiliary involvement, or advanced CF liver disease, we need to start modulators and continue modulators carefully. Up to 25% of patients will have some degree of increased AST, ALT, or GGT with modulators, but only 2 to 5% will have liver tests that rise greater than 3 times normal levels. And typically, there'll be no symptoms, and usually things will resolve. Sometimes I've had patients who get a virus, and then they come to clinic, and we happen to get their labs, and their liver enzymes go up, and then they come down, and they're on ETI. So we kind of monitor. Sometimes you need some extra blood draws in there to make sure those liver enzymes are improving. So 1 to 2% of patients who have elevations in liver enzymes will have significant elevation where we need to change the dosing of your modulator or potentially discontinue it, either for a short period of time, or if this keeps happening every time we put you back on the modulator, maybe we may not be able to use the modulator anymore. What about when we worry, or when you should worry, and if you're on a modulator or not necessarily, but when you might want to contact your clinic, your gastroenterologist and hepatologist about what's going on, what are the next steps. So if there's a rise in bilirubin, abnormal liver function tests, so those are the tests that we look at when you look at your labs. These are the albumin, the PT-INR. We don't often get an ammonia unless you are showing signs of hepatic encephalopathy, or if you have advanced CF liver disease, then we may be getting ammonias more routinely. And those labs may indicate whether things are advancing or not. So the other thing at home is if you start having yellowing of the eyes, if your belly's getting bigger, anything like that, then those would be reasons to call your clinic. So nowadays, actually, it is possible to measure ETI levels, which is awesome. Unfortunately, I don't think we know exactly what to do with the levels yet, but we're excited we have a tool that we can use to study what the levels look like in patients who have liver disease, and hopefully be able to understand how we can better modify doses in the future. I will tell you, if you are on modified dosing, that anecdotally, it still provides a lot of benefit. We have seen patients on modified dosing that still benefit in terms of their lung function and their nutritional status. Next slide. So I think Charlie kind of reiterated some of the things I already said, but I just wanted to point out two things. So he talks a little bit more in detail about there are some scoring systems that talk about when you have advanced liver disease, whether how bad it is, and if you look at your insert of your modulators, they may be talking about this Child-Pugh score and adjusting the doses based on that. And that Child-Pugh score is actually more used in adults than in pediatrics. So in pediatrics, we sometimes extrapolate from that and try to figure out how to modify the dosing. But your doctors are looking at that. If you're pre-transplant, they will also be looking at your MELD score, and those may determine safe dosing. And then he gave an antidote here where, he had to cut back to 1 orange Trikafta pill a day and may have to take it off altogether in the future if his liver can't tolerate it. And so there's also a little bit, with liver disease, rise in infections, and obviously mental stress with all these changes. So I think he just wanted to make sure that you guys had his perspective that, he himself did have to cut back on his medications because his liver wasn't happy with them and his liver labs were higher. I think we'll skip the next slide and move back to Daniela.
Hi.
Hello. Okay, so we are going to ask you a little bit more questions about before transplant than we had, I guess, discussed previously. But can you talk to us a little bit about how life was like before transplant and what challenges you had and how you managed those?
Life before transplant, once I knew I had liver disease, cirrhosis, was a little more intense just because you had to watch for a lot of things now. I could not play contact sports in high school because, that's a high risk for internal bleeding. I noticed I would get tired than the rest of my classmates during PE, so I had to adjust the best as I could. And sometimes things like that just kind of got the best of me, so I would just put most of my effort in the things that I did love to do, like certain subjects in school. I would push forward for a future I wanted, trying to get into college. I would find small joys in reading, hanging out with my friends, just simple things that I could do, and it was good.
That sounds great. Yeah, I think the not playing contact sports is the one my patients struggle with the most. If I have to tell a soccer player they can't play soccer anymore, it's earth shattering. But I'm glad that you found other things that brought you joy. Um, how do you feel like, how did you try to make your life normal pre-transplant with liver disease?
Can you repeat the question?
Yes. How did you try to make your life more normal? Like, how did you try to overcome the day-to-day struggles with liver disease before
Um,
transplant? And then we'll talk about after.
I think I did it in a pretty unhealthy way because I was scared and kind of like, you have so many questions, but I felt like I didn't have anybody to talk to because, yes, you have your transplant team, but that's not the answer I was looking for. I was looking for somebody who was going through it. So, since nobody around me was going through it, and I used to go to a children's hospital, so there's a good chance a lot of the kids were going to be younger than me, or, no one's going to, patient confidentiality, no one's going to tell you who has it too. So I got really stressed out. And at some point, I just shoved it in the back of my mind. And then it would reappear when I had appointments or when I had symptoms pop up. But after it got dealt with, I would shove it in the back of my mind again. And I realized that that's not healthy. But at some point, I realized this. So I did start talking to somebody. And little by little, I started coping and like accepting that, this was happening to me, to a point where I would hide that I had a liver issue from my friends. But as part of accepting and having that support system and, those people behind you, I started talking to them, telling them. And I think that that's where I should have started in the first place, because it was good to talk to at least your friends, just so you had an outlet to get it out. And at some point that did help. And then I did talk to my social worker at Children sometimes. But little by little, I started like adjusting, accepting, and just applying it to my life. And that's about as normal as I could make it for me.
Yeah, it sounds like you know, went through the normal stages of sort of accepting, struggling with the diagnosis and then it coming to accept it and obviously having come to the other side of it. So I'm going to let David talk a little bit about liver transplant and CF, and then we'll come back to you, Daniela, to share your experiences post-transplant.
Okay, cool.
Hello again, everyone. I think for the sake of time, what seems to be recommended here is what I will do is this. I will just very briefly run through the definition of when to consider a transplant, and then I think we will leave some of the material for the readers afterward to look through the PowerPoint slides, I think, because we're running up on time. But just very briefly, liver transplant and cystic fibrosis is certainly not necessary for all persons with CF. But there are some specific scenarios when it can be helpful and to do so. And the specific statement from the guidelines document is that for persons with CF and cirrhotic or non-cirrhotic portal hypertension with evidence of liver dysfunction, including coagulation abnormalities, abnormal bile duct tests because of bilirubin, low albumin, and refractory ascites or encephalopathy, liver transplant should be considered as the appropriate long-term treatment. And some of the things that we won't have time to discuss today or the in-depth aspects of that evaluation per se, but just know that it includes things such as evaluation of the heart, the lungs, of course, cancer screening, evaluation by social work, the liver specialist, hepatologist, the transplant surgeon, or living donor livers. One thing that is, of course, important, and we can advance to the next slide, is a determination for a smaller number of individuals as to whether there should be a liver transplant versus a liver and or a lung transplant. And this is a very nuanced discussion. I think it's more than we can generalize today. But for individuals who have an FEV1 less than 40%, it is certainly recommended to at least consider liver and lung liver transplantation. Fortunately, this is not an everyday necessity, but that goes to show that having expertise of a center both in liver transplant, but also in CF And lung transplant can be very helpful in certain aspects in certain cases. Something that occasionally can be found to be helpful is, of course, the use of ETI if the lungs are not very healthy, but they can be rescued with the medication. Sometimes that can obviate the need for lung transplant, but this is certainly something that needs to be considered in those who have advanced lung disease. Next slide. So the timing of when to be on a liver transplant list can certainly vary a little bit based on the rapidity of the decline, and that's a very specific process to different individuals. But I think the message here is to start the conversation for transplant, but also cystic fibrosis, because not all centers are experienced in both, and to have those early discussions to get some help, both for mental health support, but also for sufficient support for nutrition and all the care that's needed to take care of the cystic fibrosis, as well as preparation and undergoing a transplant. And we can go to the next slide. Okay, life after transplant, I think is, we can go, go to the next slide. And okay, one back. Yep. So Daniela, who certainly has gone through a liver transplant, will conclude probably with her assessment of how life changed after transplant, if we could. And Daniela, how did you experience the the world that is substituting in some ways one condition, which is advanced liver disease, for having received the transplant, how to take care of that and still manage the cystic fibrosis?
So life after transplant was a huge adjustment. And as much as you get that talk during the pre-transplant evaluations, you don't know how much it's going to change until it does. So for me, that was a big shocker, because now I had a liver that didn't belong to me. I was now on so many medications, and each one was to be taken a specific way. I was now severely immunocompromised, and it was stressful and hard. And now I also had to deal with the fact that since the liver isn't mine, I can reject it at any time. So it was a dramatic change. It was going constantly to labs to make sure that my liver numbers were stable, always staying on top of my meds, not missing a dose, especially that first year where it's like really crucial. It's wearing a mask everywhere I went. And since I got my transplant right around when COVID started, it was so much more intense, because I already had to stay indoors for like 2 months, but now I had to stay longer because there was a pandemic. So it was a big adjustment, but you get used to it. It's just that initial, at least for me, it was that initial year where I had to get in a routine, mentally adjust to it, realize that this was my new normal. So it takes a bit, but you learn to adjust with it and work with it.
Well, thank you, Daniela. There's certainly an image of resilience going through transplant, thriving after that, dealing with the cystic fibrosis, and doing great things and really thriving. So congratulations on all of that. I really appreciate your experience, and best wishes to you as somebody who's very brave and has really inspired a lot of us. Thank you. So we'll conclude then just with our summary and take-home points. I think as you may have noticed, we've tried to demonstrate that their awareness that CF can affect the liver is very important, and just know that the increasing recognition by CF teams and the fact that this is better being screened for and monitored is an important component of high-level care, certainly highlighted in the recent guidance. The complications and even the prediction of advanced liver disease from CF can be increasingly predicted based on some of the early screening and monitoring strategies that Meg had mentioned. I think it's important to recognize that monitoring is important if there's an abnormality that's found, and discussion of this with your team is an important ongoing assessment. The early preparation, if there are warning signs, can be very helpful in getting input from a transplant experienced team, and also coordinating with the CF team, of course. And the ins and outs of when to get on a transplant list and how to navigate that certainly are very individualized, but just know that in the right collaborative and collegial group between transplant and CF, those discussions can happen earlier. So I will then pass this back to Meg for the concluding remarks. Thank you.
All right. Okay. So we just want to say thank you again to Daniela and Charlie, who, even though he couldn't be with us tonight, contributed significantly to the development of this session. And of course, to my colleague David for agreeing yet again for me to drag him into something else. But thank you everyone for your participation and great questions. We're actually going to try to answer the questions offline and get them to you guys because we ran out of time. But before you go, please fill out the satisfaction poll, which is under the poll tab on the right-handed side of your screen, right next to the session chat. There are many wonderful resources related to this discussion, including the slides from today and the resource document found on the reception page. So please spend some time exploring the resources and download anything you want. And we hope you have a wonderful evening. And Daniela, thank you again for joining us in the middle of your night.